Okay, welcome everybody to our first Iowa Healthcare Collaborative Opioid Guardianship Quality Improvement Project. We've been talking about this project, I feel like, all spring, and finally it's coming into full play. So I'd like to introduce Brian Isitz. He is our facilitator. He is a practitioner, educator, and researcher. He's a former health policy fellow at the Centers for Medicare and Medicaid Services in the CMS Part D and MTM program, and at the CMS Innovation Center. Brian serves as a medication use quality improvement advisor for Iowa Healthcare Collaborative. So Brian, I'm going to turn it over to you.
Great, thank you, Jennifer, for the introduction. I'm very excited to be with you today. Just want to let you know is that the work we're doing is being highlighted across the nation as some groundbreaking work to help us address some of the challenges that we're having with the use of opioids. So remember, you're on the cutting edge, so let's stick with it and give it everything we've got. The purpose of why we're here today is just to ensure that patients who need opioid therapy have treatment plan goals of therapy in place for the use of all other options that are available before opioids, and then a plan for decreasing opioid use. And this is really intended for every one of us in our communities. That includes law enforcement, even the drug courts and patient advocates, and all of us working together to change our expectations of what we do when we have conditions that are, and rather than being painful, that are less comfortable. So that's why we're all here working together. Next slide, please. And really, this is just, there's many ways to look at the data going forward. Sometimes the statistics are so overwhelming, they're almost not helpful. This is just one way of looking at the Drug Enforcement Administration as beginning to plot out much of what the different agencies are saying are where heroin is the greatest drug threat. This really, as you can see, started in Ohio. The reporting has spread through the East Coast. It's heading west. We still see that Texas has not jumped on the bandwagon yet, but this really shows you in this particular snapshot that how heroin is the greatest drug threat across the nation. Next slide. And I'm going to let Jennifer speak briefly about what we have here in terms of the Iowa opioid-related overdose deaths. Jennifer?
Okay, thank you, Brian. This information is from the Iowa Department of Public Health, and when we look at this, we can see all the way back from 2000, the year 2000, and what's really happening here. You can see that heroin and opioids were kind of just running a close race, and I think, Brian, as we just talked about on the last slide, everybody's kind of looking at heroin this whole time, but really look at opioids when this started becoming big. We can look all the way back to 2009. And how much more significant this is than heroin. So it's really taken the place of that. And as we see some data here in the next few slides, what I want you to look at is I just want you to look at what's happening and take a few minutes just to enjoy these next slides. Okay, wonderful. I hope you guys enjoyed those slides. I will be sending these out so you can see these. And this was just a little snippet of what will happen when we do your community meetings. These are some examples of some data that we are going to show your community and, you know, show your families to say this is an issue and we should be paying attention to this. So here's the time that you guys all get to see who your neighbors are and who all is working on this project. So this is a map showing across the state of Iowa who all is participating in this cohort. And I'm You know, we did not handpick anybody. What we did is we just let the facilities that wanted to participate in this come forward. And Brian, what do you think about this, you know, how spread out this is? I mean, it's almost like it created the sample strategically.
Yeah, exactly. It's like we kind of just took and threw the cards up in the air, and where they fell, let's pick one from every corner of the state. So this is very encouraging.
Very nice. So here are your cohorts. So this is just a list of hospitals that are participating, and I'll let you guys look at this list for a minute. And moving forward, the owners for these projects. So we're really in a unique opportunity here. This is, like Brian was saying, this is groundbreaking information. This is a project that is not being done anywhere else. This is a group, the first of your kind, that is going on in the United States, and I think that a lot of people will follow through. So look to your left and look to your right. This is a great group of people, and I think, Brian, you've been talking about this in Nebraska and other states, and what are you hearing when you talk about this project? I mean, how are people reacting?
Well, what's happening across the country is that one of the biggest needs that as we say, the owners of the individuals working to implement these groundbreaking initiatives have said is that, boy, I wish we had a small cohort to work together to figure out how we can improve care, get treatment plans in place, bring our communities together. And here we have it with these 24 institutions, the individuals in each of these institutions, not just the owners of the project listed here, but all of you, everyone in the facility is also the owners of this project. So this is what our country is really screaming for. Give me some cohorts, some of my people who are in my shoes I can work with, and we have that right here.
Yeah, and when I look at this list, Brian, it's really impressive because you can see just a lot of different people really stepped up to the plate to say, I'm going to own this project. And so as you get your team together, I sent something out last week, and I'll be sending it again in the next week, but who should be on your team? And as you listen to our presenter today, she even mentions a few that we haven't even come with. So it's not just one shoe fits all. If you have somebody who has a passion for this or is interested, let them sit on your team because I think that's what's really going to make this project move. So just a little review work here. I wanted to go over our Compass HIN goals. So it's 10% reduction in ADEs in 1 year, and that's October 16 through October 17. Wow, Brian, that's coming right up. I mean, we're going to be on October before we even know it. And then also looking at 20% reduction in ADEs in year 2. So that's 2017 to 2018. So these are some pretty steep goals, but I really think that we can do this in Iowa. We've done it before, and we can do it again. Now looking at some of the different measures that we're looking at for this project, I just want to make sure everybody's clear on this. And as we go forward, I will send out the slides, and then I'm also going to send a list of definitions so everybody's sure of this. And, you know, if you're a pharmacist and you're the owner, make sure to connect with your quality person. So the first one is the ADE HIN definition. So we're looking at this one, and we're looking at adverse drug events using the NIC-MERP scale, categories D through I. And this is over observation and patient days. That's self-reported, so that means that can be a sample. And what I did here is I got some data so you guys can look to kind of see where we rate. This is from 2015 forward. And this is looking at all HIN hospitals. From 2015, you can see our rate was just above 5, but unfortunately, you can see that overall, we're kind of going up here. And I think that when we look at this, this is a place that we really could find some improvement. I did break this down because I think this is going to be really interesting to look at. This is our cohort. So these are our 24 hospitals looking at the ADE rate just for our hospitals. And Brian, I don't know what you think, but this is a great opportunity and area of improvement for us that we can work on.
Absolutely. And as we work together, we will definitely, as we've demonstrated dating back to 2012, we will definitely make improvements because we've demonstrated we can and we will do it again.
And you know, Brian, when we talk about this individually, this would be pretty hard to put together, but I think as a group, we're just going to be really strong and working together.
Yes.
Okay, our next measure is our inpatient statin Narcan administration. This is looking at the number of episodes when a reversal agent is administered to acute care, skilled nursing facility, swing bed, and observation patients prescribed opioids. And this is over the number of patients that are prescribed opioids. This is also self-reported. This measure we've had for a few years. Some of you have reported it, some of it you have not, but I think when you see our reporting records, you're going to be quite happy to see that most of us are. Again, I did break down the data so we can look at the difference. Here we show the stat naloxone on inpatient units for all HIN hospitals. And I think Brian brought up a really interesting point when we started looking at this. You can see May 2016, our rate was pretty low, and all of a sudden it really got high. And Brian thinks, you know, we've talked about this before, Brian, people are starting to report. So before they weren't really reporting it, now they are, and now we're like, oh yeah, we do have some area to improve.
And one of the, as we dig deeper into the measures, we also want to then see is it also being confounded by on admission or emergency room use of naloxone? So that's something we also need to explore as we do a deep dive.
Yes. So moving forward, this is looking at our cohort, just our cohort and our rate, and you can see that the rate is a lot higher. So once again, this is a place that we have a lot of opportunity to do some improvement. Our next one is the number of patients discharged from a hospital on opioids with patient-specific goals of therapy at discharge, and this is over the number of patients discharged on opioids. This is also a sampling, which we'll talk about more, but when we look at this, I think what we need to think about is we need to think about how are we doing this? You're going to hear a great example today of how someone is doing this. This again, we're going to work together. So together we're going to formulate this patient-specific goals of therapy. We're going to come together, we're going to say what's most important for the patient and come up with something that's really going to help this. So this is a new one. This slide just shows our reporting. So we're looking at the cohorts and we're saying what the reporting history is. And why I put this up is so everybody could kind of see, so there's 24 of us, and how many of us are routinely reporting? So when we start with the ADE rate, remember that's the NICMERP scale, D through I, we can show that February and January, there were 22 out of 24 reporting. March, some people may have not had their data in, but there were 17. The next one, again, looking at the stat Narcan for the inpatient population, 19 out of 24 reporting, and I'm really impressed with that. I think that nationwide, we do report very well when we look at the comparison. And next, the opioid treatment plan. This is kind of what we were suspecting, 3 people out of 24, because, Brian, they're just trying to figure out what it is. You know, are we doing it? Are we not? You know, some people are doing a really good job, and they're like, are we doing it? Yes, you're doing it.
That's very true, and we'll find out that just how to do that through the next series of webinars.
Yes, that's exactly what this project is for. So looking at our last measure that is added just for this project. So you are the only hospitals that have this turned on in your database, and all of your quality people are aware of this. But this is looking at what Brian was talking about is the stat Narcan administration in the ED. So this is looking at the number of episodes when a reversal agent is administered to emergency room patients over the number of emergency room patients. So I think when we look at this, just like our project that we did for INR, we're really going to get some eye-opening information to move forward with. So after all that data, we'll come to something that's a little bit more interesting with Anthony. So Anthony is from the Iowa Pharmacy Association. He's a graduate of Drake University College of Pharmacy, completed a University of Carolina at Chapel Hill Community Pharmacy Practice Residency, and he's board certified ambulatory care pharmacist. Anthony currently serves as the Iowa Pharmacy Association Vice President of Professional Affairs, acting as a liaison, promoting the effective and safe use of medication. So Anthony, I really want to thank you for your time for joining us today to let everybody know that this isn't just Iowa Healthcare Collaborative that is doing this project, but we're also in collaboration with you.
Yeah, definitely. Thank you, Jennifer. Thank you, Brian, for letting me have a few minutes of the time here on the webinar. And yes, the opioid abuse misuse epidemic is front of mind for the Pharmacy Association. You know, we've been really trying to tackle this, as I think all of us can be aware of it, is that it has to be a multi-pronged solution to a multi-pronged problem. And so one of the things that I'd say we're taking front and center right now is education to our members across the state. We've been leading local educational webinars, or excuse me, local educational CE sessions that aren't just targeted to pharmacists. We've actually invited prescribers, other healthcare professionals, and most importantly, civic leaders in these local communities to come out and talk about what it means to deal with opioid addiction and abuse. We've been seeing quite a bit of interesting feedback coming forward thus far. We've conducted about 5 of these so far this spring, with another 3 later this fall. But first and foremost, education is most necessary to the public, to providers, to everyone. But it can also echo issues around Narcan access, and that's where education around the naloxone statewide standing order for pharmacy has been important. Where and how do you find options for safe medication disposal? Where does technology fit into all this? And I know you guys will be talking about the prescription drug monitoring program in future webinars, but also very front and center. I would just put in a little plug for those of you that maybe hadn't been able to attend any of the local meetings by you. We'll send this out in follow-up emails, but 3 of our remaining sessions right now, we have one scheduled on August 31st in the Council Bluffs, Omaha area, one September 21st in Iowa City, and then one on October 12th in Spencer. We're also hopeful that we might have an event scheduled in the Cedar Rapids area either in October or maybe November, but we can't confirm that at this point. But I'd say one of the things that IPA has been probably one of the leaders in the country on is making sure, at least in terms of where pharmacists on the outpatient side can play a role, is with safe medication disposal. And so since 2009, November 2009, the Iowa Pharmacy Association has worked in collaboration with the Board of Pharmacy to support a safe mechanism for medication disposal. Knowing how the DEA has written rules around this and how either it's just defined, the program had been previously set up where only pharmacies can accept non-controlled substances. So you can imagine from an opioid abuse issue, it really maybe didn't have the impact that we would be expecting. But once the DEA, or once there was federal legislation, the Secure and Responsible Drug Disposal Act of 2010 was passed, and subsequent rules from the DEA allowing for pharmacies to serve as disposal sites for this, basically how it's classified as household waste, collecting these medications from the end user. In collaboration, again, with the Board of Pharmacy, but also with the Governor's Office of the Office of Drug Control Policy, excuse me, ODCP, in tandemly trying to make sure between pharmacy locations as well as local law enforcement, making sure that there's going to be an actual drug drop box location for controlled substances. One in every county is the goal. I know right now at this point there's 160 known drug drop boxes covering 93 of the 99 counties. Majority of those right now being law enforcement facilities, but I would say probably in the next year we'll see that number equalize. Will be just as many law enforcement as well as pharmacies involved in the project. What you have in front of you is a map of, I believe, where all the locations that all of you are located, and knowing that there's a local location for drug donations. And these are nice because they're permanent locations versus what you may be familiar with the DEA's National Take Back Days that occur twice a year, usually in the spring and in the fall. But what I would just encourage you, and we'll share this also in follow-up, the Pharmacy Association, working with some of our other state partners, have put together posters and other educational materials that you can hang in your hospitals and your waiting rooms, provide to any other community centers to really help educate the public on where they can go for safe medication disposal, whether that is, again, for controlled substances or even if it's non-controlled substances. And then what I would just offer in my final comments here, one other thing that I'd say we're working on at the association level, probably the next big thing is to start educating pharmacists and then our prescriber colleagues as well about around some of the new federal legislation that allows for partial filling of Schedule II controlled substances. With the Comprehensive Addiction and Recovery Act that was passed, I believe it was now just last year, actually a pharmacy could partially fill an opioid prescription. Say if it was for oxycodone, a pharmacist could have that conversation with the patient to say, they don't want to have all 60 pills that were prescribed at that initial fill. Maybe they only want 5 or 10 of them. But then that pharmacist can actually continue to fill the remaining amount on that prescription within 30 days. In the current realm, that's not, in a sense, legal what was prior to this federal legislation passing. So we're going to be working on some educational materials to try to get out that education and make sure people are aware of that this is an opportunity to maybe help reduce the amount of medications that are actually leaving the pharmacy and getting in the hands of patients or other people that end up misusing those medications. So that's all I got to say for this point. So I'll turn it back over to you, Jennifer. Thank you.
Thank you so much, Anthony. It's just really nice to have multiple people giving their input here. And one thing that I do want to say is that Anthony did provide this information to us. And so Stacy Klinger is our program manager. And what she's doing is she's working on sheets that you can hand out to your patients that are discharged on opioids, and then also something that you can keep in your ER and on your floors that show the drop-offs, so unused medication, unused opioids, where those go, and then also treatment centers, and then areas that do have Narcan that people can just go get at the pharmacy. So I think that'll be really useful information. So the resources that we're going to provide for you in the next few weeks, I hope that you really enjoy. So Brian, anything to cover after this section for you? Did you want to talk about anything or have any comments here?
No, I think this just shows the fact, when you look at the map, is that each one of these maps begins to align, showing how our communities are working together. And we'll keep doing this so we can find all the initiatives and individuals in our communities we can bring together to address what we need to get done in our communities.
Okay, wonderful. And next, our next speaker is Robin Osman. She is a registered nurse since 1985. She worked as a travel nurse for 3 years following graduation. She joined Gutenberg Municipal Hospital as a staff nurse in 1988 and was employed there until 2003, working in managerial roles since that time. She's been the director of nursing to patient care services director, and her current role as quality and safety manager for the past 12 years. So she has a lot of experience. One thing that I will say about Robin is she does move when she gets an idea. She does the rapid cycle improvement that we like to see, and she gets results. So Robin, do we have you on the phone today?
Yes, I'm here.
Okay, wonderful. You just let me know about your slides, and thank you for being on. I really appreciate you taking the time to share your story, because I think after people hear what you're doing, this is all going to come together. So you can just go ahead and start when you're ready.
Okay, thank you. So as they said, I have been in the quality department here at the hospital for the last 12 years, and we've done a number of things. But the thing that they've asked us to talk about today is our pain management work that we've done as a performance improvement project. So the first slide talks about why did our team get together. It really didn't stem from us observing opioid misuse. It really stemmed from our patient satisfaction results with relation to our pain management. So when we looked at our HCAP scores that we get through Press Ganey, who was our vendor for patient satisfaction, as you can see on the slide there, our scores were the blue line, and we are well below our peers. So that's really what sparked us talking about what do we need to do different for our patients in regard to pain, and how do we better manage that situation. So we actually got together and brainstormed who should be on this team, who should help us figure this out. So the next slide talks about who our team members are. So there's myself as the quality manager. We have 2 CRNAs that there are our full-time CRNAs, and both of them really wanted to be part of this group. I probably would not have thought so much to add them to the group, but they really expressed interest to me that they wanted to be part of the group. So of course, anybody that expresses interest gets to be on teams here. So in addition to that, we have an ED nurse practitioner because they're dealing a lot with acute pain in the emergency department. We have a family practice physician. We have our pharmacist, our surgery and pain clinic manager, our OB coordinator, our clinic nurse manager, that's a little bit unique. We actually own our family practice clinic and are working really closely with them on a lot of quality things. So this was just a natural to add them to the team. So she sits on the team as well. We have a surgery nurse because we like to get frontline staff on our team as well. A med-surg nurse. We added an EMT to bring us the perspective of the ambulance. We also own our ambulance service. And then we also got a physical therapist on the team because we were hearing complaints from our therapy department that our patients weren't being pain-free enough to be able to do their therapy. So we pulled all of these team members together, and always, next slide, always what we do at our first meeting is develop our aim statement. So that goes way back to the science of improvement process that we learned. But it really is, it keeps you focused on exactly what you're meeting about each time. And we read this aim statement at the beginning of every team meeting. So we decided on our aim statement as, again, it's focused around patient satisfaction still at this point. So by December 31st, 2017, the Pain Performance Improvement Team will improve the HCAHPS rolling quarters pain management top box score to 70% or greater through implementation of best practice standards. Next slide. So this slide talks about our team meetings, and I already said our first meeting was really devoted to developing that aim statement. In addition to that, we always start out any performance improvement team that we have together around brainstorming so that everybody feels like they have input into how we're gonna work and how we're gonna prioritize our initiatives. So we came up with our top 5 initiatives, and they were nurse and physician education, patient education, use of comfort scale and comfort function goal, scheduled around the clock non-narcotic pain meds, and then anesthesia consult in collaboration with the primary physician for patients that had uncontrollable pain. Next slide. So talking about our first initiative, we decided to start with staff and physician education, really to get everybody on the same page around how we wanted to treat our patients' pain, so that nursing staff was talking the same language as the physicians were talking, and treating the patients accordingly. So we took the advice of our pain clinic specialist, Keith Barnhill. He's a CRNA. Like I said, he's a pain management specialist, and he's also a national presenter on pain management practice. So he did education sessions for our nursing staff as well as our physicians. We made it mandatory for nursing and physicians, and then we also invited anybody else in the hospital that just had an interest, especially our rehab services, our physical therapy, and occupational therapy, just so they could have some education as well on how we were going to manage our patients. So that education I included there, like what it all included. It was characteristics of pain, the impact of pain, both pharmacological and non-pharmacological pain control options, how we evaluate the pain management, pain perception, the attitude and beliefs around pain, cultural change requirements, and then breaking down the barriers to pain management. And then what we decided to do at the end of that session, next slide, is we found on the Press Ganey website, Press Ganey is our patient satisfaction survey vendor, we found a pain management promise for caregivers. And we took it to the committee, and the committee felt strongly that every nurse and every physician really needed to have the same beliefs and the same way that we were going to manage our patients' pain. We did find that we had some nurses withholding medications when they didn't feel like the patient was really having as much pain as they said. And then we had the other end of the spectrum where we had nurses giving as much pain management as the patient wanted. So we really needed to come to some terms about how are we really going to manage these patients. So this promise is just something we asked every nurse to sign, which they did. We also took it to our medical staff and asked all of our physicians to sign this, and ended up with some really good discussion, but in the end, the physicians really did not want to sign something. From a legal perspective, they had some concerns about signing, anything that really an attorney or somebody else didn't look at. So they did agree to what was in the content of the promise, but really just chose not to sign that. We were okay with that. Next slide. So our next initiative then, once we had all of our staff and physician education done, was really to work with the patients on education. So we took our patient guidebook and revised the pain section of that guidebook to talk about just what they should expect, and that we have to develop a pain goal, and what are some alternatives to pharmacological pain interventions. And then both our nursing staff and our physicians have to continuously educate our patients about these things on a day-to-day basis, and do. Next slide. Then our third initiative was a little bit, sorry. The third initiative was a comfort function goal and a comfort scale. This was really brand new to our organization, but it came about from one of our CRNAs who actually had done a lot of research around pain. And he just threw out there, why don't we try to approach this in a little different manner? Rather than ask patients, how much pain are you having? Why don't we ask them, how comfortable are you? His perception around pain is that if you ask patients about pain, they're going to assume they must have pain. It really is that subliminal message that we're trying to avoid by using the word pain. So we changed that then to say, develop a comfort function goal. So it really is, what level of discomfort would you be able to function at doing your normal daily activities? And speaking to the patients that we probably are not going to get your pain to a 0. That's an unrealistic expectation. So what do we need to do to get you to a level that you can do your normal daily activities? And then changing the question around, give us your pain score right now. We thought, let's change that to, tell us what level of comfort you're at right now. Again, avoiding that word pain. So what we're actually in the process right now of testing this. So we've not gone to full implementation on this because it's such a big change. So we have in one of our patient rooms, we've changed the whiteboard to match a comfort scale as opposed to a pain scale. And then we changed the pain score, we changed to a comfort function goal, so that patients give us a number that they would be comfortable at, and still be able to function doing normal daily activities. So we just did an evaluation of this at our last staff meeting, nursing staff meeting, and the initial feedback that we got is that this is a nice test, but unfortunately, it's not big enough to be able to fairly evaluate it. It's only in one room. They really feel like we need to make it bigger than that and add some additional rooms, or just go to full implementation of it, and let's just test it let's just test it and see how that goes. So we pulled our group back together just recently, and we are going to look at full implementation for a short period of time, and then reevaluate what that looks like. Next slide. So we'll give you updates as we go along with this test, but certainly nursing and physicians are excited about the change. The other thing that we did a number of years ago is we set a policy in our emergency department that we do not prescribe any narcotic pain medications for patients presenting to the emergency department with chronic pain. We'll manage acute pain, not necessarily with narcotics, but we really felt like there was a lot of people coming in wanting us to write prescriptions for their pain medications. And so it's probably been 7 years ago that we posted this, and we have this posted right in our emergency department window. So right as you come into the ED, this is the first thing that you'll see. So, and then we do reiterate that to patients. So they are well aware that we are not gonna be their refill line for their narcotics. So on the hospital side, that's kind of where we're at. We obviously still have some work to do, but we feel like we're making some really good progress on that side. Now I'm going to flip over to the Cornerstone family practice side. I said earlier that
Robin,
we own
before you move on.
Sure.
Robin, before you move on,
Yep.
can we ask you some questions about just the
Absolutely.
hospital side of this? Because
Sure.
Brian, I don't know about you, but I'm just like feverishly writing this and like, oh my gosh, that's amazing. Like they're actually doing this.
Well, yeah, it's exciting. I want to wait till Robin's done because she adds more and more excitement every slide.
I know. Well, one thing that I did want to ask, that there was a question that came in. How did your patients react to this opioid policy? It sounds like in your ER you've been doing this for 7 years, but how about the inpatient side? How did your patients react to this?
So on the inpatient side, obviously this is new for them as well. But we really have not had any pushback from patients, and we did just recently, I don't know if you could see on our graph, but we actually are on the uptick on our patient satisfaction around pain. So I do think we're making some progress there. And in addition to that, we did just have a patient that was in this room that we were trialing this, and actually she sits on our patient experience team, but didn't know what we were doing around pain management. And she just had so many good things to say. We're just now getting that out to our staff to say, this is our first really great positive feedback using this room that we were testing this new comfort level and comfort function goal in. So she had nothing but great things to say about it.
Wonderful. And then one more question. What is your hospital size and what's your average daily census?
So we are a critical access hospital, so we're licensed for 25 beds, but our average daily census is probably 6 to 8. So pretty small.
Okay. Perfect. All right. So now I'll let you move on. I just wanted to make sure that those questions were asked and covered before we moved on to some more good news.
Sure.
Okay.
So now this is from the clinic side, and we have our clinic nurse manager is actually the one that worked on this program, but based on the number of opioids that they were prescribing and the misuse or the frequent calling to have prescriptions refilled, really sparked them into looking at what do we need to do different, just based on we have so many people that request refills. So it really was, they have a nurse that does our medication refill line and actually manages all the refills for the clinic. And she's the one that really said, we really are getting a lot of requests for pain medication refills. So the clinic nurse manager met with the medical director of the clinic and looked at developing a program using, they went out and they searched all the best practices around this. around, what do you do with patients that are on opioids, and should you be doing different things. But in addition to that, they sought the input from all of the clinic providers and the nursing staff, because they were, obviously dealing with these patients. The program that I'm going to talk to you about has been in place at the clinic for about a year, and obviously they've made adjustments, over that year, but really have come to a pretty solid program. It's used by every clinic provider, and it's used consistently for every patient that gets prescribed opioids. Next slide. The first thing that the patient has to do when they join this program, so they had people that were already on opioids, they had to become part of the program, and then any new patient that is prescribed opioids gets put into this program as well. The first thing they have to do is sign a medication use agreement, and this agreement really talks through what are my responsibilities as a patient in this program, as well as what is the clinic responsibilities to do. So both the patient and the provider responsibilities, like I said, are listed out. There can be no refills before they're due. So if they got a prescription for 30 pills, they couldn't call next week and request another prescription. They have to treat our clinic staff with respect, and with that same regard, our clinic staff have to treat them with respect. They have to agree to drug screen routinely. And the drug screens, it's a little bit confusing why they do a drug screen, but the drug screen really is done to make sure that the patient is taking their medications and not doing something else with them, selling them or that type of thing. They have to agree to a random pill count. They cannot do any outside drug seeking, and that is checked routinely. And they have, the clinic has a zero tolerance policy. So any non-compliance, the patient can be discharged from this program and not prescribed narcotics after that. Lost or stolen medications are never refilled. The only time that would be refilled is if they had a police report indicating that they've made a claim. And then that agreement is reevaluated every year just to make sure that the patient's still understanding the program and agreeing to all of the program components. Next slide. So the first component of the program is the patient has to complete what's called an ORT, or an opioid risk assessment. And that, like I said, is completed by every patient prescribed opioids or have been on opioid therapy. And it's done at the beginning of therapy, and it really is looking at how much risk is this patient at to misuse opioids. So what are the risk factors of misuse? What is their family history, their personal history of substance abuse? And then is there any psychological disease processes that kind of go along with that? Then based on the score of that, we'll tell them what their next step needs to be. Next slide. Another component is the patients have to come back into the office at least every 3 months in order to refill the medications past that 3-month time frame. At each office visit, then, the patient has to complete a pain assessment that details specifics about their pain. And this is kind of twofold. It tells the physician, do they still need to be on these narcotics or opioids, or also, do we need to do some further testing that this patient's pain is just not under control? They're continuing to need opioids. Is there more going on here than we first thought? Next slide. In addition to that, there's also another tool that's completed as an ongoing risk assessment, and that's called the COM tool, or the Current Opioid Misuse Measure. This, again, helps identify any potential for misuse of the opioids. It's a questionnaire that's completed by the patient, and it really helps determine, what is the best treatment for this patient. I talked earlier about this urine drug screen. That urine is collected at every 3-month office visit and not necessarily run every time. The provider tells the nurse if they want that run or not, so the patient doesn't always know if we're running that or not. And again, the goal here is we want to detect that they're using the medication and not misusing it or like selling it or those kind of things, because we did have some issues with that prior to this program. It also tells us if they have any other illicit drug use going on that, you know, maybe we should reconsider the use of opioids in the interaction with these other illicit drugs. The provider can request this random drug screen, though, at any time throughout the program. Currently, we do that testing here in the hospital through our lab department, but because we have some satellite clinics in different towns, we are looking at possibly getting some point-of-care testing to be able to do those urine drug screens. Next slide. Each patient in the program does have a folder so that that has all of these agreements, the assessments, all of that in it. And we are on electronic medical record in the clinic, but just felt that we really needed this to be readily accessible to any nurse at any time for any patient that's in the program. The other thing that we are in the process of doing is opening an urgent care program. So we have already decided with all of the partners that we've been working on with this urgent care is that we will have a no narcotic prescription plan for that, just as we do for the emergency department. The goal there really is to make these patients accountable to their primary care physician and that team, and not seek medications from other places that maybe we might lose track of. So that pretty well wraps up what we do on the clinic side, what we do on the hospital side. And I think what we do really well as a hospital and a clinic is really work well together, so that we're aware of what the clinics do and the clinic's aware of what we're doing. And it just makes it obviously better care for the patients. So I guess I would encourage every hospital to reach out to your clinics and find out, you know, what are they doing, you know, around pain management. And then the last slide just is our contact information. Joan Parker is our nurse manager at the clinic, and she'd be happy to entertain any questions or provide any tools that you might need. Same thing for myself. You contact us at any time.
Wow, Robin, thank you so much for sharing. And I think I like that you work together with your clinic, and as you implement your urgent care, that the patients are really getting the same message. So there's no confusion, and you guys are standing strong on what's best for them.
Right, right. Yeah, it's just really important. We really want to channel them back to their primary care physician who really can manage that whole program.
Wonderful. Brian, did you have any comments before we move on to our next section here for Robin?
Yes, Robin, first of all, thank you so much. It's just so impressive to see what you're doing. You know, sometimes when you're working inside your community, your four walls, you don't realize the impact you're making. And this is really serving as a model exemplar for our nation. I just want to highlight 5 key points of one of many that you talked about. You emphasize the positive aspects of recovery and to reduce the unintentional or subliminal consequences of returning patients to functional status. You talk about the use of comfort scales and comfort function goal, the positive aspects. Around-the-clock use of non-narcotic everything, the staff reorientation, refocusing patient family expectations. All of these put together are going to make a dramatic difference. And I can't thank you enough. And for those who may be listening or watching at home, you'd have fun if you could see me in my office. I got the map of Iowa out, and I'm tracing my route so I can come down and visit Gutenberg. Well, so thank you, Robin.
We'd love to have you.
Great, thank you.
Thank you so much, Robin.
Well, thank you for letting us present.
Okay, so moving on, Brian. Inquiring minds want to know. I think that we've just heard everything you're going to talk about without her even knowing what we were going to cover in this next screen. This is pretty exciting.
It really is. And I'm just going to take a couple minutes to talk about what a medication treatment plan is generally, and how we apply it to individuals not in pain but who are in discomfort, if you will. I think the big picture here is to think about goals of therapy for any medical condition. it's been one of the missing links from our healthcare system for a long, long time, is that we just really have thrown drugs at patients, if you will. And just everything else in life, we have goals for what we want to do in the next 2 to 5 years with our grandchildren, with whatever our career may be. But really, we haven't set these realistic expectations for the use of our medication. And so in the case of patients in discomfort, this is comprehensive and integrative care plan to ensure effective and safe use of opioids when indicated as adjunctive therapy. So I flipped that. Usually adjunctive therapy was everything else, opioids first. No, we've flipped the paradigm. It's established in shared decision-making with patients and families to optimize the use of non-drug and non-opioid therapies first. Goals of therapy are measurable, realistic, and patient-specific using this comfort scale, rather, so we have some objective measures to improve quality and function and quality of life, improve the comfort levels, reduce pain, and limit opioid use if and when needed to the lowest dose for the shortest amount of time. And then we will have this objective, patient-specific measures to guide step-down therapy with scheduled follow-up evaluation. The days of someone's discharged and sent home with 100 Vicodin, those should be long behind us. Next slide, please. And really, what we're addressing here is our medical community's contributing factors. All right, we have a responsibility, as you said, is that we have really used opioids to get people out the door, if you will. They're in pain. We're realizing that it's a comfort scale, and you're not going to get to zero pain. All right, that's not realistic. Some of the factors include the fact that we've had this medical training pendulum where it's swung backwards, back and forth from, we're using too many opioids, now we're not using enough, let's give everything we can back to restricting use. We've underestimated the importance of setting goals of therapy. We're focusing on pain rather than comfort. It's the importance of assessing prior patient experiences and opioid naive status. Many times we don't, for instance, opioid naive status, we give someone oxycodone, send them home, and I've seen too many times the bottle says take 2 every 4 to 6 hours as needed. Folks don't know what as needed means. They take 2 every 4 to 6 hours. 2 days later, they're being carted off with respiratory distress in an overdose situation. Understand what has happened in previously to a patient's experiences, whether it be with dental surgery or whatever the case may be. Thinking that it's not happening in my backyard, yes, sure, we have a low use, what appears to be based on national data. We have a low incidence compared to other states, but if you're the family of someone who had a preventable overdose, it's one death is too many. We're in this fee-for-service. We have been in the fee-for-service prescribing dilemma. If I don't walk out of the doctor's office with a prescription, I've been shortchanged. The doctor has to see a patient every 6.2 minutes. Really, as we move to a value-based or outcomes-based financing, where the team helps manage patients, we change that so that we keep patients healthy and out of the facilities. We've talked about the unrealistic patient expectations in the absence of shared decision-making. It's about comfort control, not doing everything possible for pain. And that leads us to one of my biggest complaints I've had with what used to be called Consumer Assessment of Health Plan Survey, the hospital version of the Consumer Assessment of Health Provider Survey. There's 3 items that are in the pain domain. And one of them, item 14, did the hospital staff do everything to help you control your pain? Well, that's setting an expectation of 0 on a 0 to 10 pain scale. And CMS has recognized that this is contributing in many ways. As Robin pointed out, they had low scores here. Well, CMS is no longer reimbursing hospitals for those 3, for high values and no 3 pain. They've been pulled out of the value-based payments. And so that's really, I think, in a nutshell, that's 2 of the things, the big picture of having these comfort management treatment or functional status improvement treatment plans, maybe a better term, and that we're going to be working on together based on Robin's experiences and others across the country. And then Robin, Jennifer, next slide. Really, we have sent out some resources previously. We'll continue to share those with you. Request anything and everything you can. We've got the file. The file is about 6 feet tall right now of all the resources. We'll find out how to help you use them through both coaching as well as peer support. With that, Jennifer, I'll turn the program back to you.
Thank you, Brian. I like that you bring up the point that every patient counts. We don't know how many people are reporting, but it is time to, not be embarrassed of this and hide this information, but really talk about it, and let's prevent it. When we think of the upstream story that we heard at our learning community, and it was out on Innovation as well, let's catch it upstream before it gets to the waterfall, and these things have to happen. So when we look forward, these are the survey results, and Brian and I both want to thank you guys for filling out these surveys and letting us see what you guys need. This was the reason for the survey. We really wanted to see where you were so we could provide you the information that was important. So the first one, what percentage of your inpatients discharged on opioids have a pain management treatment care plan? And we can see that 8 out of 24 were not sure. And the biggest group was they do not have a process for this. And I think, Brian, this is why we're here. We're here to work together in a group so people can have this process in place.
Yes,
Next, what
true.
percentage of your emergency room patients discharged on opioids have a pain management treatment care plan? Once again, this is some stuff that we're going to work forward, but no, we do not have a process for this. And the next one is I am not sure. So it's kind of the same information. And Brian, when we think about this, this is kind of what we expected, no matter which group of hospitals that we brought together, because this is groundbreaking. This is new.
And this is going to help us see some, if you will, called hot spotting. Sometimes we may not know the information. Maybe it is zero patients, but maybe it's not. And so this is information that will help us and help our communities.
Okay, on to our next question. What other pain treatment options do you offer patients, not limited to? So we can see the majority of people are doing Tylenol or anti-inflammatory, and some exciting things that I've been seeing lately are comfort menus, which I will be sending out to you in the next week. So you can see this, but I just talked with a hospital, and what they actually do is they take their comfort menu, laminate it, and they put it on the side of the bed. So when the patients and families are sitting there, it's kind of like room service. They say, yeah, I would like a back massage before I go to bed, or yes, I'd like a drop of lavender, or, this is the kind of music that relaxes me, instead of saying, I can't sleep, and then the nurse calls the doctor to get a sleeping aid. Let's try some other measures that will work for that as well. I think that's going to cause a lot of discussion, and then also patient satisfaction, because when we look at those activity scores on the patient satisfaction, this would also be included in that. So we'll be sharing some of those menus and moving more forward with that as well. How are you educating your patients about realistic pain management goals? And, as we talk further, and after I heard Robin talk, should we be talking about realistic comfort management goals? This verbiage may change for us. So you can see that 13, we're using the whiteboard to keep track of the pain goals. Discharge planning, I don't even see anybody that chose discharge planning. Initiation of treatment plan, and then other was 5. So I think this is a great area of opportunity for us to improve. This next one, how often do your providers or other hospital staff access the prescription drug monitoring program database prior to providing opioid prescriptions? What we're seeing here are 14 out of 24 were not sure, 2 were never, 1 to 25%, 7, and then 1 person was 25 to 50. So if I'm reading this right, I'm seeing that, it's under 50% for every single person. And we're going to have a lot of discussion on this on our second webinar. We'll have some experts in this area that have done this, and how does it work? How does that look? And once again, how is this best for our patients? Our next, what percentage of patients discharged on opioids are candidates for the transitional care management services? 22 said they were not sure, and then 2 said that 0 to 25%. So Brian, as we move forward, I think this will be something that will be eye-opening and, help a lot of people to know exactly what resources are available. What do you think about this?
Well, absolutely. I mean, one of the questions we have to address, it's called the 10,000-pound gorilla in the room, is how do we bridge from fee-for-service to value-based payments? And CMS is helping us with a number of codes. For instance, so the transitional care management is one option. We can also look at individuals with chronic pain and then look at the chronic care management CPT codes also are there. So working as a community means including our billing folks together to meet those specifications, which are clearly laid out in these one-page CMS fact sheets on the use of each one of these codes.
Okay, thank you, Brian. And on to our next one. Do you know where the medication drop-off for opioids is in your area? I know that we just saw this. 15 said yes, 9 said no. Well, here we go. So this is your first gift. We are going to come out with that for you for every county. There'll be a listing that you can hand your patients when they're discharged. There will also be a sheet that your medical staff can utilize. And you know, when Robin talked about what they did with their clinic, and they really shared resources. This is something that we really hope that you share not only with your clinics, but also with your EMS and any other areas in your area that you'd like to share that with. Does your institution provide or participate in education and awareness for your community about the safe and effective use of opioids? And we can see that 19 out of 24 basically said, I'm not sure or no. So this is something that is going to lead into what I'd like to talk about next is our community meetings. I know that you've seen these on the emails when I talk about community meetings, but the purpose is to educate your community on the safe and effective use of opioids. So as you move forward with this project, your patients and your community will know what to expect, and they'll also be excited to know that you care enough about them to concentrate on this. So from our survey, 83% are not currently offering any community education on opioids. So this is a great opportunity for us. So what you can do is you can schedule your meeting during the day or in the evening. I have sent out dates. Our presentation is about 1 hour long. So what we ask is that you open the meeting and that you close the meeting and that we are your guest speaker. Facilities, you can really open and close as you want. So if you have something else that you'd like to talk about, or if you'd like to just explain why we're there, that would be wonderful. What this is going to do for you is this is going to drive your community support of the safe and effective use of opioids, and also move your project really down the road a lot faster. So when we look at this, what I do want to share with you is those dates are open. Do not be scared of community meetings if you're not having them, because we are going to provide some resources. You can see here are some resources, and again, I'll send these slides out early next week. But here are some resources that you can look on how to do this. You can also contact me, and I can help with that as well. So I'm really excited to do these community meetings. I apologize, I know we're right up about an hour. We're just gonna go a little bit over this information you've seen before. I'll go through this quickly. But basically what we're asking for your commitment to participation is to report data to us. We're looking for the measures that we talked about, the ADE, the inpatient Narcan use. New is our ER use of Narcan. And then, of course, looking at the number of patients on opioids with patient-specific goals of therapy at discharge. We ask that you completed an initial and final survey, and Brian, they all completed the survey, so that really makes me happy to show that we do have some hospitals that are really ready to participate here. So Brian and I both want to thank you for doing that first step. The next section here, we'd like you to share your successes and challenges with cohort colleagues in addressing the use of opioids in your community. So when you're doing something, please get on Innovation and share. If you get a success, if you get a challenge, let's have group discussion on here. I did notice that most of you are already on Innovation, and this is where we will have our discussions. Next, we would like to have an All Teach, All Learn 4-month quality improvement cohort project using the rapid cycle PDSA method. And also to formulate an opioid guardianship team. We've talked about that in the last email that I sent you, and that will be ongoing. And hopefully, listening to Robin, she gave a great example of who's on her team and why. So hopefully you got some ideas from her as well. Our 3 webinars are today, July 13th, and September 21st from 11 a.m. to 12 p.m. We would also like one person from your opioid guardianship team to be present at our IHC annual conference to be recognized for the work done during the project. I know when we talk about this project, it may seem little to you, but it's really big and it is groundbreaking. And we would like to recognize you in front of everybody to say thank you for making this important, and thank you for the work. And I think when we see the results, you're going to be very proud. Our offers to you are quality improvement consultations, virtual and on-site visits with opioid improvement coaches, community education on the safe and effective use of opioids, national recognition, local recognition. We will be doing the data analysis for you and sending run charts so you can see your progress. We're also going to provide you, like Brian said, I think we have a file that's about 6 feet tall right now of evidence-based best practices and emerging new resources. And after today, I think that we see that with Robin's presentation, she's a great resource. And I know that Robin has offered to share a lot of her documents and things that she talked about today, so I will be sending those out as well. Benefits of participation are a list of narcotic drop-off sites in your county, list of narcotic drop-off sites and treatment centers in your county that you can share with your medical staff, sharing of successes, interventions, and best practices, peer support in developing opioid treatment plans, community outreach to increase access to Narcan, and coaching from our expert pharmacists. So some action items for success. Data, data, data. So when we look at improvement, we have to have data to support that. Sometimes we think we're doing well and we look at the data, maybe we're not. Or we think we're not doing well and we look at the data and we're pleasantly surprised. So as you do this, again, Innovation is a great place to go. How are you collecting the treatment plan? What sample are you using? So all of those questions, please feel free to ask each other and to ask one of us as well. We would like you to form your opioid guardianship team. If you have not already done that, this is the time to get that working. And as the owner, when you committed to be the owner, we would like you to send out the emails to everybody on your team to make sure there's one person, because a lot of times if everybody's owning the project, then nobody owns it. So thank you again to the owners for offering to be the owners of the team. Teamwork on the treatment plan. Join and participate on Innovation. Schedule your community meeting and schedule coaching time with Brian. I'd like to leave you with this quote. I begin to realize how important it was to be an enthusiast in life. If you are interested in something, no matter what it is, go at it at full speed. Embrace it with both arms. Hug it, love it, and above all, become passionate about it. Lukewarm is no good. So when we look at this quote, I hope you think about this project, because we do need to embrace it and we do need to go at it with full force, because I think that the improvement that we're going to see over the next few months is just going to knock everybody's socks off. So Brian, do you have any closing remarks before we wrap this up?
No, really, thank you to each of you again for participating, because we're on an awesome journey together, and this should be very interesting to see how well we do. Thank you.
Thank you, Brian. So our next webinar is July 13th at 11 a.m. I will continue to send you weekly emails with new information that will help you during this process. And once again, contact us at any point if you have questions. Everybody have a great week.